To all who are new here, welcome. This is Relevate Sports Medicine's virtual journal club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or you can sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. There are multiple handouts, including the PowerPoint for today's talk, available for download from the dashboard. The recording will be available for review from our website tomorrow. Our speakers this evening, I'm proud to present, are Dr. Neha Raukar and Jennifer Rheeling, Certified Athletic Trainer. Dr. Neha Raukar, prior to her current academic appointment, was on staff as a sports medicine and emergency medicine physician at Brown University starting in 2006. She was director of the Division of Sports Medicine from 2010 to 2018. In 2018, she joined the Emergency Medicine and Sports Medicine faculty at Mayo Clinic. Since 2008, she has been an editorial reviewer for Sports Health, a multidisciplinary approach. She's an advisory board member on the Sports Medicine Advisory Committee of the Korey Stringer Institute. She is also a member of the National Federation of State High School Athletic Association Sports Medicine Advisory Committee. Jennifer Rheeling completed her master's in athletic training at Indiana State University. She has been working in the secondary school setting for the District of Columbia Public Schools since 1991. She received the Most Distinguished Athletic Trainer Award from NATA in 2019. She is the chair of the National Athletic Trainers Association Secondary School Athletic Trainers Committee. She is the NATA Liaison to the National Federation of State High School Athletic Association Sports Medicine Advisory Committee. She is a Hall of Fame inductee to the Mid-Atlantic Athletic Trainers Association. Together, they, along with a group of other sports medicine leaders from across the United States, developed the return to sports and exercise during the COVID-19 pandemic guidance for high school and collegiate athletic programs, which was published in June and was endorsed by ACSM, NATA, Korey Stringer Institute, National Federation of State High School Associations, and the Gatorade Sports Science Institute, among others. They will be speaking today about returning athletes to play during COVID-19.
Thank you for that introduction. We appreciate it greatly. I just want to give a slight introduction to our talk today, and then I'll turn it over to Dr. Raukar for our first segment. The onset of mitigation strategies in response to COVID-19 was abrupt and total in many communities. In the ensuing time period from early to mid-March, it is safe to say no one was unaffected by measures such as self-isolating, ramped up hygiene practices, mask wearing, possible illness and/or quarantine. The long-term effects to society, the economy, and what was once considered normal have yet to be fully realized. The pandemic has left no less devastation amongst athletic trainers, resulting in widespread loss, temporary or otherwise, of employment. And for secondary school-based athletic trainers, speculation runs rampant on the potential long-term dismantling of interscholastic sports, as it seems many student athletes have turned to youth sport organizations for participation, as they are largely less regulated and more revenue-oriented. The purpose of our talk today is to give an updated snapshot and perspective of what we know today and how that relates to our practice. Globally, according to the World Health Organization, there have been over 33 million cases, resulting in over 1 million deaths. In the United States, over 7 million cases have been identified, with just over 200,000 deaths. leading all other countries in both categories. Community transmission, evidenced by the inability to relate confirmed cases through chains of transmission for a large number of cases, is the classification assigned to most cases in the United States. We have no financial disclosures, and really our goal is to provide guidance based on the rapidly evolving science and keep everyone who takes care of athletes at the forefront of science. Dr. Raukar?
All right. Dr. Honey, if you could just advance the slides. And one more. So we have no financial disclosures, as we just talked about. So thank you for that introduction. So it sounds like the coronavirus is terrible and evil. However, it's not new. They are known to cause diseases in humans and animals, and there are over 1,000 strains around the world. In fact, 4 of these strains are known to all of us, as they are the most common causes of the common cold. They typically infect only the upper respiratory tract and cause really relatively minor symptoms, as we know. However, there are 3 coronaviruses: the severe acute respiratory syndrome coronavirus, SARS, the Middle East respiratory syndrome coronavirus, MERS, and now the SARS-CoV-2 that can replicate in the lower respiratory tract and causes pneumonia, which ends up being fatal at times. So you might remember the SARS outbreak in 2002 or the 2012 MERS outbreak, both of which led to fatalities. One of the reasons that SARS-CoV-2, COVID-19, is so much more deadly than the other coronaviruses is that people can transmit the virus before they show clear symptoms. So, as the virus secretly reproduces, and we'll have a little crash course on virology, it's also killing lung cells. When the immune system does hear the call to action, it goes into overdrive, suffocating or at least negatively affecting the very cells it's trying to save. So if we can advance the slides. Okay, so how does this happen? So here we're going to get a little crash course in virology, which I think will arm you against some of the hype that surrounds this virus. So the virus enters the body. It binds to the angiotensin converting enzyme 2 receptor, the ACE2 receptor. The organs considered to be most vulnerable to this virus are those that have higher levels of ACE2 receptors, such as the lung. The receptor is predominantly present in actually the epithelium of the lung, the mouth, and the nose. And it's found highly abundant in alveoli. However, as we can tell from the symptoms that it presents, receptors are also found in the heart, the esophagus, and the kidneys, the bladder, and the intestine. So when you go through your symptom screen every day or every so often, that's why these organs are listed. It's important to note that children less than the age of 10 have a lower expression of these receptors in the nasal epithelium. And that explains why COVID-19 is less prevalent in children. And since they don't have the same hefty viral load as adults, why children are actually considered a buffer against transmission. So the virus binds to the cell, enters the cell, and using the cell's own machinery, like any other virus, it replicates. New viruses exit the cell and then enters or infects other cells. Like any other virus, these infected cells trigger the body's own immune system, which tries to destroy the virus. But then the viruses can prevent or intercept these signals, buying time to replicate widely before a person even shows symptoms. SARS-CoV-2, the virus that causes COVID-19, has some really special properties that resist this initial immune response, which also contributes to its infectivity. All right, let's move on to another slide. So when we consider transmission, let's move on one more slide. Oh, go ahead, Jen.
I was going to say, actually go back a slide. Thank you. All right. Here we're going to talk about mitigating transmission. The recommendations regarding the care of patients with or suspected to have COVID-19 includes things like cleaning and disinfecting between patients, etc. However, in the athletic training healthcare facility, you have largely eliminated all of the positive and suspected positive patients through your screening, which we'll talk about later. So things like an N95 mask, generally used during procedures that aerosolize the virus, like intubation, are generally overkill. Cleaning removes dust. We'll talk about the differences between the different stages of cleaning. Cleaning removes dust, debris, and dirt from a surface by scrubbing, washing, and rinsing. Sanitizing refers to fabrics, and it reduces the bacteria identified on the product's label on surfaces and in laundry. Disinfecting is our goal, as it destroys or inactivates both the bacteria and viruses identified on the product's label, like influenza and rhinovirus, on hard, non-porous surfaces. Just a side note, you may have noticed when coronavirus first started, as we knew it, it was actually already on labels. That's because there were other strains of coronavirus. We just probably didn't pay too much attention to it in general. Disinfectants are the only products approved by the EPA to kill viruses on hard surfaces. EPA-approved sanitizers only have claims for bacteria, while disinfectants have claims against both bacteria and viruses. The EPA has a search tool for list-in disinfectants, and the website is there in the middle of the slide. This search tool, you can put in either the EPA number or the name of the product, and it'll let you know what it is effective against. We have provided that link on the screen, as well as one for a document prepared by the Kansas Department of Health and Environment, which provides a good overview of cleaning, sanitizing, and disinfecting procedures. And a quick word about hand washing. Soap kills viruses and is the best defense against the spread of COVID-19. Soap molecules disrupt the coating surrounding the virus, and once the viral coat is broken down, the virus is no longer able to function, dries out, and dies. 20 seconds of hand washing with soap is optimal because you work up a good lather, allowing the soap to react with the viral coat and break it down. While the process is reasonably fast, it's not instantaneous. As a matter of fact, soap works better than hand sanitizer, so if you have a choice, always pick soap. And by the way, it doesn't need to be fancy antibacterial soap. All soaps work the same. Advance the slide. Thank you. This chart just shows OSHA's outlined risk categories for health workers, healthcare workers. Most activities athletic trainers usually engage in would likely fall in the lower and medium categories, with a relatively infrequent exposure in the high category. And again, daily screening puts us in the lower tier. It should eradicate higher risk individuals. Standard precautions are recommended for all patient care. They're based on risk assessment and make use of common sense practices and personal protective equipment use to protect healthcare providers from infection and prevent the spread of infection from patient to patient. Transmission-based precautions are the second tier of basic infection control and are to be used in addition to standard precautions for patients who may be infected or colonized with certain infectious agents, for which additional precautions are needed to prevent infection transmission. And we would use airborne precautions for patients known or suspected to be infected with pathogens transmitted by the airborne routes. Advance the slide, please. And on this slide, we are the recommended routine infection prevention and control practices. Implement telehealth and triage protocols whenever possible. That way you can eliminate unnecessary individuals in your athletic training healthcare facility. If you can take care of them without seeing them in person, then that eliminates more bodies in the area. Screen and triage everyone entering healthcare facility for signs and symptoms. You can screen them ahead of time, and again, we'll talk a little more about screening later. Then you'll reduce the amount of at-risk individuals that you are exposing to other people. Implement universal source control measures, which are basically masks. The more people, I'm sure on social media, most of you have seen the cartoon with the guys wearing jeans, and if both guys aren't wearing jeans and one guy pees, he's going to get his pee on the other guy. And the more jeans that are still in place, the less pee is being transmitted. So that's just a good, especially I work in high school level, it's a pretty good visual for high school kids so that they get it. Encourage physical distancing whenever possible. Implement universal use of personal protective equipment. I would say sometimes I get a little lax about that. Now's not the time to be lax. If you're working in facilities located in areas with moderate to substantial community transmission, which I would say DC was for a long amount of time, you're more likely to encounter asymptomatic or pre-symptomatic people. So just keep that in mind, that you're at in a higher risk area. And if you work in areas with minimal to no community transmission, continue to adhere to standard transmission-based precautions. And that's just a quick note to remember, everybody's kind of experiencing this differently. If you live in a rural area with low population rates, COVID's probably not as big of a deal as it is to those of us that are in major cities. So just remember, everybody's kind of experiencing this a little bit differently. And advance the slide, please. And I'm going to turn it back over to Dr. Raukar.
Well, let's advance one more. Okay, so we talk about a little bit about transmission. So let's talk some more about it. So primarily, we're told the virus is transmitted from person to person through respiratory droplets, and you can see this little cartoon here. These droplets are released when someone with COVID-19 sneezes, coughs, or talks, and this virus has to be inhaled to get into the lungs. The World Health Organization recommends a physical distance of at least 1 meter, which is 3 feet between people. So enough people are concerned about the potential transmission, so we use this distance of 6 feet. We also worry quite a bit of transmission between surface to human, but there are no cases of this worldwide. So in short, the virus has to be inhaled, and since it is transmitted by respiratory droplets and not aerosolized like TB or measles, there's no long-range transmission, so 6 feet is an adequate distance. Transmission is greatest when people are symptomatic, and especially early in symptom onset, which is the reason that we screen every day. Transmission may occur during the incubation period, typically 1 to 3 days before profound symptom onset. Pre-symptomatic transmission is reported in about 1/5 of the number of cases that occur. Then when we talk about transmission, people are really worried about transmission from asymptomatic cases, which means laboratory confirmed cases who do not develop symptoms. However, contrary to all the fear, evidence is quite limited about asymptomatic transmission, and the World Health Organization states that asymptomatic cases are actually much less likely to transmit the virus than those who develop symptoms, and asymptomatic cases are not the major driver of overall epidemic dynamics. So numerous studies, like I said, have reported no evidence of asymptomatic transmission from carriers of COVID-2. All right, so advance the slide. And I guess I should mention, for those in the music who are trainers in the music industry, a large study was just done by the National Federation of State High School Associations, and they found that a lot of the wind instruments actually aerosolize the virus. So it's no longer airborne transmission, it's now aerosol transmission, and for which you need more protection and more space between people. So the disease. So symptoms of the disease can vary from person to person. They also vary depending on different age groups. Some of the more commonly reported symptoms are shown here, and we know them because we use them every day when we screen athletes. However, when we talk about children, infected children typically report less severe symptoms, and when they do report symptoms, the most common are fever, cough, and myalgia. But remember, symptoms can take up to 14 days to appear after exposure, and the average is about 5 days. In all ages, only 6 symptoms have a sensitivity of at least 50%, and these are cough, sore throat, fever, myalgias or arthralgias, fatigue, and headache. That's like every teenage kid, right? Of these, fever, myalgia or arthralgia, fatigue, and headache are the red flags because they have a really high positive likelihood ratio, and their specificity is above 90%, meaning that having these symptoms substantially increases your likelihood of having this disease. So in some schools or some groups have to pick the top 5 symptoms they're going to ask. If you had to pick, these are the best ones to ask about. And then something that we should consider as we enter a cold and flu season, it's going to be a real challenge to identify those with COVID versus other viral illnesses like the common cold or the flu. But note, upper respiratory symptoms like runny nose and sinus congestion are not part of the screening questions for COVID because they're more common with cold and not COVID. Could you advance the slide, please? So the thing we worried about, though, is complications, right? So we worry about the complications so the complications that have the highest likelihood are venous thromboembolism, cardiovascular complications, and acute kidney injury. Those with moderate likelihood include acute liver injury, neurologic complications, and what we call COVID lung. So in the interest of time, we're going to talk about the the three most common complications. Okay, so thromboembolism first. These are clots. And the prevalence of this and this leading to a clot in the lung is 26% and 12% respectively. And we're not really sure how these clots develop. We think it's due to the direct effects of the virus on the endothelial layer of your blood vessels, or the indirect effects of just being sick and lying around. These clots can appear anywhere and therefore can lead to a variety of symptoms. So deep vein thrombi are the most common, so which presents as calf pain, like it's a DVT, which can embolize to the lung, causing a pulmonary embolus. And if the clot in the lung that presents to the lung is large enough, it can be fatal. Acute kidney injury can develop at any time before or during a hospital admission, and can occur during the post-infection phase for a couple of years, in fact. So if you have a patient returning to play post-COVID admission, you've got to watch the use of the medications such as NSAIDs, as we know they affect renal function, and we have to keep these athletes really well hydrated. So if you have an athlete that's admitted to the hospital, for the next couple of years, you're going to have to watch their kidney function and watch their NSAID intake. And the one we talk about the most, and the one we're most scared of, is myocarditis. It's inflammation of the myocardium, which results in myocarditis, heart failure, arrhythmias. It can result in acute coronary syndrome, rapid deterioration, and sudden death. So a study looking at 100 patients who had recently recovered from COVID-19 MRI found they had ongoing myocardial inflammation in 60% of the patients, independent of pre-existing conditions or the severity of their disease. So we're going to delve into this a little bit more, since it's the one we fear the most. So can you advance the slide one more? So of patients hospitalized with COVID-19, we know that 10 to 28% have evidence of myocardial injury, and it has a death rate as high as almost 70%. So after recovery from COVID-19, the cardiac MRI reveals myocardial edema, so swelling of the heart, 54% of the time, and scar formation about 30% of the time. So the long-term structural changes that occur from scarring in general myocarditis are pretty well known and include sudden cardiac death and arrhythmias. The characteristics unique to COVID-19 have yet to be discovered. However, we do know that in regular myocarditis, the rate of ventricular arrhythmia is about 7%. And what we're seeing is in COVID-19 induced myocarditis, the rate of ventricular arrhythmia is 78%. So if you had a person who had COVID-19, there's a pretty good chance they're going to have some kind of ventricular arrhythmia. Is it fatal all the time? No. In fact, most of them are probably unknown to the public, but they do have it. So this leads to questions regarding the impact of these observations on the clinical symptoms and the return to sports participation, and really lends support to screening for COVID-19 during the preseason and basically every day. So the American Academy of Pediatrics recommends that people who have severe presentations such as low blood pressure, arrhythmias, or people who needed ECMO, or who had kidney or heart failure during their admission, they should be treated as though they have myocarditis and should be restricted from exercise and participation for 3 to 6 months. That is the American Heart Association and the AAP. They must be cleared to return to sports by their pediatrician, who will likely refer them to cardiology, a pediatric cardiologist. All right, so one more. So we have, this was recently published. It's the algorithm for how to clear somebody who has symptoms of myocarditis and other considerations as well. So let's look at let's look at this graph with some detail. If we start in the middle where we have confirmed past infection, you have mild infection, moderate infection, and severe infection, and then you have folks with ongoing cardiovascular symptoms. This graph will be available to you. It's in one of the articles that you have, but let's just talk about it a little bit. The initial EKG remains a first-line test in patients in whom myocarditis is suspected and can show non-specific ST changes. However, I want you to note EKG changes are only found 47% of the time, so it is not the gold standard. So if you have an abnormal EKG, great, have the person worked up further. If you don't have an abnormal EKG. So if your EKG is normal, that should not be 100% reassuring, because if the patient still has exercise intolerance and you can't explain it from just deconditioning, then that person needs to be worked up. In patients in whom you do suspect myocarditis, the American Heart Association recommends cardiac imaging, such as an echocardiogram or cardiac MRI. And you heard my statistics regarding cardiac MRI earlier. Echocardiogram has a couple of specific findings, and cardiac MRI shows very can show very subtle changes kind of early. So those with a probable or definitive diagnosis of myocarditis are restricted from participating in sports, because during the acute phase of viral myocarditis, you have an unstable myocardial substrate, which leads to necrosis, fibrosis, so scarring, and then eventually you'll have a pro-arrhythmic myocardium. So you're going to have arrhythmias. No test correlates with resolution of the inflammation, so you can't say, oh, are you feeling better? Oh, you're feeling better, let me get you back to play, because you don't know the level of inflammation based on symptoms. So the clearance of patients with confirmed myocarditis has to involve EKG, echocardiogram, and possibly Holter monitoring. So it has to be done by a pediatric cardiologist. In the US, this clearance occurs no less than 3 to 6 months after the initial diagnosis. In Europe, by the way, there's a standard 6-month restriction from activity before people start investigating clearance to play. Okay, next slide. All right.
Okay, here we're going to talk a little bit more about screening, and the screening should help minimize your exposure to positive or potentially positive persons. Education is critical to emphasize the need for screening, the need to be truthful during screening, and the importance of staying home when screen answers elicit positive responses. Site-specific plans will be based on local ordinances and facility capabilities. So maybe not everybody will have somewhere to quarantine somebody if they suspect them of being positive. So those are all things you're going to have to consider when you're making your plans. Consider electronic screening methods that can be done off-site and with no contact with others. Many athletic trainers are using Google Docs or some other form where the patient can do it ahead of time. You can see the answers on your end. You would know, Neha, I had some positives, go home. I don't know why you're here. Don't come. So that should all be done off-site whenever possible, and so that nobody else is at risk. And they should be, you should read those answers. You should look them over prior to. You don't want somebody being there for 20 minutes and say, hey, you're not even supposed to be here, get lost. So we all know how high school kids in particular, I don't know about other sets of patients are, but high school kids, they're going to do their best to show up and hang out with their peers whenever they can. And then this should be done by everyone. A common question is, do you have your coaches? Are you your athletic director? Everyone that's on site should be screened. Everyone should be there. And people who aren't necessary to the program shouldn't be there. I know in my setting, I have coaches who like to bring their kids, or, maybe my student aides are babysitting. That's not the day to come. And so nobody who doesn't have to be there should be there to minimize any kind of extraneous exposure. And then develop your plan for persons with positive responses. What immediate actions are you going to take? What procedures are you going to put in place for return? And that may be dictated by your local jurisdiction. Are they going to have a physician's note? Is there some other plan that you're going to go through? Do they just need to show up with a negative test result? What do you need in your setting for them to return to athletic participation? And make sure that you know what protocols to follow regarding reporting to officials so that appropriate contact tracing can be done. Next screen, please. Here we're going to talk a little bit more. Neha already covered some of this, the data on the signs and symptoms. So this is just this red flags. These are the 4 that she mentioned that are the largest indicators of whether you have a potential positive COVID case, that you're dealing with. So that set of symptoms right there, those are the ones that should raise your concern the most and that you should look at referring out. So stop the spread. These are, again, this is a sample health screening question. There's 7,000 of them online. You can find those anywhere. Interestingly enough, here, I think our school system thought ours was a little too lengthy, and we're probably going to have to shorten it down a little bit. So we'll be looking at some of these red flags here to focus on. So next slide, please. And as we know too, there's been a lot of talk of people who are at increased risk. And generally speaking, that's increased risk of severe illness from COVID, not necessarily increased risk of contracting COVID. So people with many of the things that we would assume, asthma, hypertension, kidney disease, cancer, sickle cell, anything that affects primary organs and stuff, if those people become COVID positive, they are at a higher risk of becoming severely ill from the virus. So just a side note on that, it's not necessarily just a higher risk of becoming infected with the virus, but a higher risk of being severely ill. This slide here, this shows one of our deconditioned athletes coming back after a long layoff. And just the need, again, I mentioned at the beginning that we know many athletic trainers have suffered some job instability in this situation. Not only is that a concern for the athletic trainers, but that's a large concern for our patients. As they are getting ready to come back to participation, somebody needs to be there who is implementing best practices to take care of them and knows the signs and symptoms of, you know, the things that Dr. Raukar just talked about. Somebody needs to be fully well aware of what to watch and how to look out for those things. So again, here are some links to some resources for you. The AMSSM NFHS guidance, that's cardiac issues in high schools. And again, I apologize, I did kind of focus on high school athletes, and I forgot that we had a broader audience. However, these are all easily findable on NCAA websites and everywhere else. And so, and you're welcome to reach out to us. We'll be more than happy to help you find any kind of resources that you may need. KSI had in June put out an article on return to sports and exercise, and outlines slower approaches to reconditioning and reacclimatization, and why those things are important, and gives some good programs on how to do that more safely than just jumping in with both feet. And I just wanted to point out this quote here from the National Federation guidance. It was very well received by the athletic training community, that the National Federation made a stance and said, given the coming financial crisis at the state and local levels, the NFHS SMAC fears that athletic trainer positions will be seen as a luxury, and those positions will be at risk during the budgeting process. It is also assumed that athletic trainers supplied to high schools by hospitals and sports medicine clinics are also at risk, as many medical clinics and hospitals have suffered severe revenue loss during the pandemic. Athletic trainers in high schools are positioned to play a vital role as sports return following this pandemic. As healthcare professionals, they can take lead roles in developing and implementing infection control policy throughout the school. Whenever needed, state associations and their SMACs should promote the importance of athletic trainers in high schools and their role in injury evaluation, treatment, and risk minimization, as well as being a vital component of any return to school and athletics plan. Most of that can be translated to any setting athletic trainers work in. And, you know, the revenue loss and the financial difficulties, they definitely translate across the board. So some variation of this could be true in any setting that athletic trainers are found across the board. For many individuals, the onset of COVID-19 related mandates required isolating at home and restricting access to schools and fitness facilities, and prevented access to equipment, resulting in a gross reduction in overall activity levels that may have lingered, may have lingered for months. Coupled with a return to activity that has been sporadic and varying across the nation, many of our patients will return to activity in a declined state of fitness than they are accustomed to. This may make them more vulnerable to injuries and illnesses, and a graduated, elongated ramp-up is strongly recommended to allow for appropriate conditioning and acclimatization where necessary. This should not necessarily overlap with competition preparation. Several states and collegiate conferences, which had initially suspended fall athletic competition seasons, have recently reversed their stance. Unfortunately, this delay in beginning the season prompted shortened timelines from the commencement of practices to the first competition date in many instances. This means athletes may be resuming activity with competition around the corner, and competition may come at the expense of proper conditioning or essential skill development. Again, the links on this slide provide some resources for more appropriate conditioning parameters. So, and I think, is that the last slide, Dr. Henny? I couldn't remember if we had another one. Oh, emergency preparedness. Yeah, I didn't have notes for this one. This is pretty self-explanatory. So athletic trainers are master risk mitigators, and I think being prepared is our motto in all things. However, now is the time to make sure that you're especially sharp and on point. Reevaluate your policies and procedures. Make sure that they are reflective of what's going on in the current climate. There was a post on social media, an athletic trainer, a kid was suspected positive and his parent just refused to take him. And if we don't know he's positive, then he doesn't have to self-isolate or quarantine or stay home. Well, if you had a policy or procedure addressing that, then it's a non-question and they have to go through the thing. So make sure your policies and procedures are reflective of what may come up in this time period. Update and practice your emergency action plans. Again, in particular, as it relates to cardiac events, make sure your AEDs are in working order, good batteries, good pads, all those fun things. Ensure the accessibility and emergency response supplies and equipment. Ensure your PPE is readily available, used correctly, and plentiful. Educate, educate, educate. You're going to have to educate all stakeholders, your parents, your patients, your coaches, your administrators, everybody that you work with, so they're on the same page and they understand why we're going through all these things. I think in the school setting, a big problem, like I mentioned in regards to youth sports earlier, is we look at things primarily from a liability and a risk mitigation perspective, whereas youth sports are looking at it more from a profit perspective in a lot of cases. I won't put that on everybody, I won't generalize. So therefore, we have to be a little more conservative and cautious. Which of course in my mind is the right way to go. So a lot of education, a lot of answering questions. Be prepared to be flexible when updated information becomes available. What we know now regarding COVID-19 as compared to what we knew in March and May and July, it changes vastly. And the longer the virus is around, the more we'll understand the long-term effects. So make sure that you're staying updated and just be prepared to pivot and be flexible with what is coming. I get a lot of questions and I just keep saying, we don't know what we don't know yet. And we just have to move when we do get better information. So, you know, I think that's what's made it difficult in this time period. Everybody wants absolutes and black and whites, and there just aren't any with COVID. And then finally, to my athletic trainer colleagues out there, self-care is critical. Please make sure you're taking care of yourself. It's a big burden to be an athletic trainer. You know, we're often overworked and understaffed, and this is just going to add to it. So just know we're all in the same boat. We're all going to get through it, and this will not be permanent. Any final comments, Dr. Raukar?
I would say this is the time to advocate for a medical timeout before every athletic event, before every competition, knowing that myocarditis is a friable myocardial substrate, and you're likely going to have a ventricular arrhythmia, especially with exercise. This is the time to practice your emergency action plan, and this is the time for every single person to know how to use their AED. Other than that, go out there and have fun.
Awesome. Well, thank you guys. I'm starting to have questions pop into the question tab. And for those out there who have burning questions and want to be able to ask them, please don't hesitate to put those into the question tab. So the first one here comes from Mary. And Mary's asking about whether there are collegiate recommendations that in regards to a similar flow sheet, and if there's things to consider, different cardiopulmonary considerations for those athletes that may be more developed.
I can take that. So the flow sheet actually goes for people of all ages. It was also endorsed by AMSSM, so it's for people of all ages, the flow sheet that we showed. And the developing athlete, we actually know quite a bit about the myocarditis in the developing person. And they looked at college recruits and found that they had that viral myocarditis was their most frequent cause of death over a 20-year period. So it's not just a disease of the young, it's a disease of all ages and all athletes. The NCAA website actually has a treasure trove of information, so you could just play around on there one day, but the AMSSM website, that graph is on their website.
Yes, and I think I was printing this off while we were going. I believe there are a new one that came out that's specific to the collegiate, and I was pulling it up. It's from the AMSSM website. I'm not sure if you're able to see that as just another one, but still very similar. So the question here about with the athletes that you're involved with that have had a previous positive, what does your return to play progression look like post recovery from a COVID infection?
So we know this, right? We've all been very well versed with return to play post concussion, right? It looks very much like that, just dragged out longer because you're looking for exercise intolerance. So, but it looks exactly the same. Jen, you can answer that a little bit with more detail, probably.
Yeah, that was exactly what I was going to say. It looks very similar. I would be very sure to have written documentation of what is done every day. Again, we don't know exactly how this is all going to play out, but yeah, it's just anywhere from I've seen plans anywhere from a full week to about 14 days. And again, when you have to assume that you're starting at a lower level than you normally would, and working your way back up. And again, you're looking for exercise intolerance, making sure that they're re-engaging in the way you would expect them to, maybe a little bit slower. A lot of coach education is going to need to take place all the way around. But yeah, it's very similar. And again, Arkansas, the State High School Association, they have a good one out that's pretty thorough and detailed. It's got sign off, check off lists, so that you know who's looked at the athlete, that they did get clearance, and what stage they're on going through. So, but it's very similar. Again, plenty of those out almost everywhere. So.
I have a question here from Kelly, and that's about the incidence of myocarditis. Is this something that we're just seeing in those hospitalized cases, or are we also seeing it in those who may have gone through treatment at home or were asymptomatic who tested positive?
The statistic I gave where 60% of the people had inflammation of the heart, that was all comers. So it was some were treated at home. I think a third were treated in the hospital and the rest were treated at home. So it's all comers, all ages. More detailed studies are coming. The Mayo Clinic's doing one, for example. And so we don't have enough data to know specific to COVID, the rate of myocarditis. We just know it's higher than what had been previously seen with other viral infections.
There's a question here about when we have positives, at what point to discuss putting the whole team into quarantine versus putting just individual players.
That's all you, Dr. Raukar.
That's a slippery slope that thankfully lots of schools, lots of state associations, because it's very specific to your locale, and it's very specific to your community transmission rates. There's a lot of variables that play into, does the whole team need to go into quarantine? Does the opposing team that you played last weekend need to go into quarantine? There's a lot of things that go into that. At the high school level, each state association has thought this through. At the collegiate level, this has been thought through in some detail. And in youth sports, I would follow the high school recommendations, but knowing that kids don't transmit as much as older people do.
All right, and now this question from Nadine is about cardiac screening. When do you assess them with an echo? Can you go into a little bit more detail of who gets what level of cardiac assessment?
So looking at the algorithm helps a little bit, but okay, so you do an EKG, that's your first line because that's easily accessible. Cardiac MRI is only available at big academic centers. It's not available everywhere. Transthoracic echo is available, a much more readily available, not as readily available as EKG, but it's much more readily available. And so this is typically done under the auspices of a pediatric cardiologist who knows the local resources. The gold standard, by the way, is endometrial or endocardial biopsy, not endometrial, endocardial biopsy. But that's actually frowned upon given the infectivity of COVID-19. So we're not really biopsying. So we're using these other imaging studies in lieu of biopsy. And so it really depends on your locale. So if the EKG is abnormal, refer. If the person is exercise intolerant or has symptoms like shortness of breath or chest pain or palpitations or near syncope or straight up passing out, refer. And let the pediatrician or pediatric cardiologist, depending on what your resources are, figure out which algorithm they're going to go down.
And I think she posed in their stress test. Would you defer to the cardiologist, stress tests and additional cardiac testing?
Yeah, so stress test won't pick up myocarditis. What was the other test you just said? That won't pick up myocarditis. But yeah, again, it's under I would defer to the pediatric cardiologist. I guess intolerance, doing a Bruce protocol would pick up myocarditis, but that's not really the point of the stress test. It's storming in Florida.
So there's a question here about the troponins. Troponins, I guess, they're talking about them a little bit more in terms of utilizing them during the initial evaluation. What has been your experience utilizing troponins?
So troponin, so for those that don't know, troponin is an enzyme that's released from myocardial cells that are basically dying. The troponin is elevated even when there's a pericardial effusion. It can be elevated with myocarditis, obviously. It's elevated when there's somebody having a heart attack. It's not specific, nor is it sensitive for myocarditis. I work in the emergency department. We don't even get troponins in the initial assessment of anybody. So while it's good to look, it notices damage, it doesn't tell you really anything because you don't have, unless you're following it or you had it, you have something to follow from, it's not really very useful.
All right, I have a shout out here from Rachel. So she's sending love from your favorite Brown Sports Medicine staff. And she also asks, how important is the reading of an EKG? Should it be done by someone who's familiar with athletes or certain races, or can it be a cardiologist who's a general cardiologist?
So that's tricky. So there are sports cardiologists who are very familiar with the athlete's heart, which, as we know, the athlete's heart looks different on EKG than a regular person's heart. It looks, actually, the EKG of an athlete's heart looks pretty scary compared to a regular normal EKG. And so, but I think most cardiologists, especially those who are interested in taking care of athletes, are pretty well versed. I would say they're pretty well versed with the athlete's heart EKGs. If you have, and the racial differences that can occur on EKG as well. I would not leave it to just anybody, and I would certainly not leave it to that little computer diagnosis on the top, because that's generally wrong.
So there's a clarifying question about where we were talking about before with the cardiac needs for return to play and the cardiac evaluation. The question is, so in an athlete with mild symptoms, should all athletes, if they have mild symptoms, have an EKG before attempting a return to play, preferably before initiating any exertion?
That's a tricky question because the EKG is only 47% of the time going to show you myocarditis. And so it depends really on your pretest probability. If you think this person really has something, then have them seen. If you're not really sure, I wouldn't hang your hat on a normal EKG. So and you have to sort of tease out, which is delicate, who has myocarditis and who's just exercise intolerant. So if you notice, hey, they're not catching their breath, they're still out of shape, and it's been a couple of days, then yeah, I would refer that person. I would not be comfortable clearing based on an EKG.
And in those who have they undergo a cardiac workup, and that cardiac workup doesn't find specific findings regarding myocarditis, what might be the next step? If the cardiologist says, clear to return to activity, and they're continuing to have exercise intolerance.
So don't forget the other big manifestation, the other big complication of COVID is clots, right? And so it's cardiac workup, but it should be cardiopulmonary workup because there could be something going on with the lungs, like a pulmonary embolus. And that's seen fairly frequently. Anecdotally, I'll tell you, there's quite a few athletes that I've encountered who have had pulmonary emboli, and their presenting symptom was exercise intolerance, shortness of breath. I can't work out like I used to. I can't even race up the stairs like I used to. And so if the cardiac workup is coming up empty, just think about, and that's why the pediatrician can oversee this because they'll do the cardiac, they'll refer to cardiology, and if needed, they'll refer to pulmonary to get the pulmonary workup done as well.
Do you then, in those circumstances, did their screening D-dimers, did you start with a D-dimer? You
can't. The D-dimer follows Bayesian logic. And so if your pretest probability is not close to 0, you can't use it. So you can't use it. COVID causes an amazing elevation in D-dimer just by existing. And so you can't use D-dimer. If you think PE, they're going to need more advanced imaging.
So there's a question here regarding should they be taking a baby aspirin with return to play after COVID?
Well, but then the other problem with baby aspirin is that it affects your kidneys, which we also know is a problem in COVID people. So I would say no.
Okay, this question comes from Amanda. And she says, do athletic trainers have to worry about risk of stroke in these athletes if this is causing embolisms?
So to have a stroke, you would have to go from the right side of the heart to the left side of the heart. And so you'd have to assume that there is some communication like a patent, like a PFO. So while I guess a theoretical and potential problem, it's unlikely, but theoretically, yes, can exist. And we don't know the numbers, so I can't say, oh, it only exists this percent of time. We don't know.
Just waiting here to see if there's any last burning questions, because I think we've hit most of them now.
Shout out to my friends at Brown too.
All right, so I'll go ahead and conclude us here. So you are going to receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz and evaluation. You're going to have 72 hours to complete that combined quiz, evaluation, and assessment. You can always contact us with questions. Here's the email address. Our next upcoming lecture is going to be on October 20th, and that's going to be with the team psychologist for Florida Atlantic University, talking about mental health in the college athletics setting. All right, so thank you everyone for attending, and thank you so much to our fantastic speakers today. An awesome lecture, very timely. I know we're all going through a lot of this right now every single day, so I appreciate everyone's time.
Thank you all very much.
Thank you.
Feel free to reach out if you have questions.
Absolutely.
Have a great night.
Bye, you guys.